Logos, Department of Health and Human Services, CDC. Text, and Schuchat, MD, Consequential Epidemiology, an EIS Love Story. April 24, 2025. Anne speaks to an audience from a podium on stage. Behind her is an American flag, a flag with the Department of Health and Human Services seal, and a flag with a seal that says U.S. Public Health Services 1798. Slide. Text, Consequential Epidemiology, an EIS Love Story. Anne Schuchat, MD, former Principal Deputy Director, CDC, Rear Admiral, U.S. Public Health Service, retired. Langmuir Lecture, Annual EIS Conference, April 24, 2025.
Wow, it's really incredible to be here, and I'm so delighted that EIS can have a conference, that everybody's here or watching the stream, and that I have the incredible honor of being the Langmuir speaker. I was a teenager when Alex Langmuir left the CDC, and so I didn't have direct, experience with him being a mentor. I did give a talk once in Baltimore where he was in the audience, and I had a little taste of what it was like to have Alex Langmuir ream you after your talk. So for the current EIS officers who've been doing such a great job at this conference or who will be speaking tomorrow, you're lucky, right? It may be the only thing you're lucky about. So my title, no. My title is Consequential Epidemiology, a Love Story. I have to remind myself to move with my microphone, so I didn't get the coaching all of you guys got in EIS. But
a photo of Bill Foege receiving the Presidential Medal of Freedom from President Obama in 2012. Text, Consequential Epidemiology, a tool to change the world, not just study it.
I wanted to start with this idea of consequential epidemiology. For the newer EIS officers, this is Bill Foege receiving the National Medal of Freedom Award for his incredible work on smallpox eradication and many other things. He was CDC director from 1977 to 1981, then helped stand up the Carter Center and then the Global Task Force for Child Survival, or Global Health, I believe, helped stand up the Gates Foundation, a real literal giant in public health. In 1983, he gave the Wade Hampton Lecture at the American Public Health Association meeting, and he coined this phrase, consequential epidemiology. There were debates in academic circles about whether epidemiologists should do the science or should actually take on advocacy, activism, or action, really. And he stood firmly on the side of action and thought of epidemiology as a tool to change the world, not just to study it. So the concept is really central to what we do in public health, and that phrase that he talked about was echoed in speeches later on by other giants like Ward Cates and Jim Marks and Sandro Galeo. Recently, Judy Wasserheit convened a panel at the American Epi Society on this theme. And since I was invited to do that talk like about 2 days after that panel, that is why I'm titled the talk, The Consequential Epidemiology.
An EIS love story? A man and woman embrace on a beach, with the woman holding a bouquet.
Now, in contrast, the EIS love story, spoiler alert, this is not going to be that kind of love story. There will be no salacious details, no scandals disclosed on mic, but on the theme of love stories, I imagine a lot of folks right now are feeling a bit of heartbreak, and I don't personally have answers to all the disruption or the attacks on CDC or public health that we're experiencing. But I know that our work matters, and I know that it's essential. And I know that the people in this room really share the passion that I have for consequential epidemiology and making a difference.
A red line crosses through the photo of the man and woman.
Right, it's not that kind of love story.
Text, from the EIS history books. A section of the MMWR Morbidity and Mortality Weekly Report from June 5, 1981, with the heading, Pneumocystis pneumonia, Los Angeles. An etching of a large regal building labeled the Bellevue Stratford, Philadelphia. A book titled 11 Blue Men by Burton Roosh, with an illustration of a hand with blue fingers. A tattered box of Rely tampons, with the slogan, Rely, it even absorbs the worry.
So For me, EIS was basically love at first sight. Even before I got to CDC, I knew about the EIS history and a little bit about CDC, and that EIS and CDC were making history by saving lives. Of course, there were the New Yorker stories about the detective or discovery work that EIS did, written up by Burton Rouchet. There was the very public mystery disease in Philadelphia at the Legionnaires' Convention when a new cause of pneumonia was identified. The first cluster of what we now call AIDS, reported in our very own Morbidity and Mortality Weekly Report, and that terrible toxic shock syndrome identified in young women when I was in college and was a whole lot like the women that were coming down with that. EIS didn't stop with discovery. There was a linkage to action. You know, taking the pump handle off of the pump in John Snow's Britain. And that commitment to action is really central to our DNA. So in thinking about how to address this talk and topic, I decided to kind of go a little bit to the movies and a little bit to that idea.
A film clapboard that says "Meet Cute" on it appears next to a photo of 5 men and 2 women standing together in a small office in the 1990s smiling at us.
So sometimes love stories take the form of rom-coms, and sometimes they start with a bit of a meet cute, if you know what I will. So I'm looking at some of the people in this picture now, and it's really weird, right? We were young ones, okay? So I decided that talking about EIS and consequential epidemiology, it's infinite. You know, I could spend days and days pulling random examples of EIS officers making a difference in the public's health. So today, our cast is shown here. This is the gang that much of the gang that I was part of early on in my days in EIS and shortly after that. This was the meningitis and special pathogens branch in bacterial diseases back in Building 1 on Clifton Road, which is no more. And so I'm going to talk about some of the work that these individuals and colleagues did that are really illustrative of why epidemiology is a tool for change.
One of the men is shown cropped out of the photo, standing next to a line graph titled, "Decline of Hib Meningitis Following Introduction of Hib Conjugate Vaccines, Children Less Than 5 Years, U.S., 1980 to 1991. The graph has years 1980 to 1991 on the x-axis and cases per 100,000 from 0 to 25 on the y-axis. A dot appears at each year, connected to make a line with a downward trend. It begins at about 19 in 1980, peaks at about 23 in 1984, goes down to about 18 in 1988, then goes down to about 5 in 1991. A point on the line between 1987 and 1989 is labeled 18 Mo. A point on the line between 1990 and 1991 is labeled 2 Mo. Text, source, Adams W.G., JAMA 1993.
So this is Bill Adams. He was an EIS officer in the early 90s, and he worked with an EIS alum, Jay Wenger, analyzing a surveillance project, a surveillance system of passive surveillance on bacterial meningitis that states were reporting in from around the country. And they were able to show an 82% decline in meningitis caused by Haemophilus influenza B, or Hib. Before vaccines, Hib caused about 20,000 cases of meningitis, pneumonia, or sepsis in young children in the United States. Many of these children who survived developed hearing loss, intellectual challenge, had to be institutionalized, or required intensive home care. So this was a really bad disease that pediatricians used to struggle with. But conjugate vaccines that linked a protein conjugated to a polysaccharide were able to overcome the immunologic barriers that babies had and actually protect children. So you can see this huge decline in disease shortly after the vaccines were licensed, but I'm going to blow up the last 5 years.
A box appears around the line on the graph from halfway through 1986 to 1991. A new graph, titled Hib Meningitis Declined in Less Than 1 Year Old Group Before Vaccine Licensure for This Age, shows only 1987 through 1991, with 3 lines. The first line, representing less than 1 year, begins at 50 in 1987, peaks at about 55 in 1988, then drops down to about 15 by 1991. A point on the line just before 1988 is labeled conjugate vax 18 months, and another point just after 1991 is labeled conjugate vax 2 months. The line representing 1 year begins at 30 in 1987 and drops to about 8 by 1991. The line representing 2 to 4 years begins in 1987 at about 5 and ends at about 0 in 1991.
And what you see in this inset is multiple things. Bill and Jay did the classic epidemiologic complicated tool of stratifying their data by age. And what you can see in the white line is that babies under 1 year of age had very high rates compared to the older children. But you can also see that even though the vaccine was only licensed for babies, for toddlers 18 months of age and over, there was a huge drop in incidence of disease in the youngest age group right after the vaccine started to be used. And this was really the first glimmer that conjugate vaccines could have indirect protection. People who were vaccinated were less likely to carry the bacteria in their nose and throat and spread it to others. It was a huge finding, replicated by others besides Bill. And that finding meant that these vaccines were not just effective, they were hugely effective and cost effective, and they could actually be a game changer for very high burden countries where the disease was worse. Other EIS officer alums worked on Hib vaccine introductions around the world, including Rana Haje, who helped introduce the vaccine essentially in 73 Gavi-eligible countries. And other EIS officers helped show that later conjugate vaccines against other kinds of meningitis like pneumococcus or meningococcus also had properties of indirect effects or herd effects.
A cropped version of the photo now shows 2 women and 2 men. Text, the refrigerator study in the MMWR. A screenshot of an online 1-paragraph article from MMWR Weekly from April 21, 1989, titled, Epidemiologic Notes and Reports Listeriosis Associated with Consumption of Turkey Franks. Text, Turkey Frank case leads to USDA to institute zero tolerance policy for L. monocytogenes. Incidence of disease falls by 40%.
So now back to that original cast. When I joined CDC, our branch was very focused on listeriosis. Now, EIS has a long history of involvement with foodborne diseases, from salmonella to botulism to E. coli 0157H7, a lot of landmark work besides just the potato salad at the church picnic. Some of you of my era will remember that case study from the summer course. But listeriosis had caused foodborne outbreaks, but it wasn't so clear how important it was, how important foodborne contamination or foodborne disease was in sporadic cases of listeriosis. So we collectively in the branch embarked on a series of studies. Bob Pinner, who is here, led the infamous refrigerator study, where colleagues in state health departments collected food from the refrigerators of patients with listeria and sent them into our lab at CDC, Clifton Road. I got to lead the case control study that was a lot of phone interviews with patients around the country. And Jay Wenger helped with a whole lot of stuff. So the 3 of us were EIS officers at the time. Early on in our study, the Oklahoma State Health Department that was part of this project found a patient who had listeriosis, a very severe kind of disease. And our lab found the very same fingerprint of Listeria monocytogenes that the patient had was also present in turkey franks from her refrigerator. They also sent us unopened packages of turkey franks. Those also had the same very rare fingerprint of the bacteria. And Jay flew off to Texas to work with USDA and the state in investigating the plant. Okay, I think that this MMWR, which I got to write, may be the shortest MMWR in MMWR history. I think I saw a couple MMWR people here who could verify that. But the word count is probably the most cost-saving word count that MMWR has ever had. So immediately after our MMWR, a batch of lobbyists and people from the poultry industry descended on CDC, and very soon thereafter, within like a week basically, the USDA issued a zero-tolerance policy for Listeria monocytogenes in ready-to-eat meat. It was extraordinary as an EIS officer to see the power of CDC, of the MMWR, of evidence-based, clear proof of a causal relationship between contaminated food and a really bad disease. Another EIS officer, Jordan Tapero, later characterized what happened after that new policy went into place, or I like to think about it as after my MMWR. The incidence of listeriosis fell by 40%. You know, I still get chills to think of how our science can lead to policy that can save lives.
Another cropped version of the photo just shows one of the women. Text, a word about mentors.
A word about mentors. This is Claire Broom. She was the chief of the meningitis and special pathogens branch and our original mentor. I could say so many things about Claire, but probably shouldn't. She was a graduate of the EIS program and knew how important this 2 years was in the training and development of public health professionals, and taught me so many things. I hope each of the new officers is lucky enough to get a mentor like Claire. You will be forever grateful. One of the things that Claire did was orient me to a project I was going to work on Group B streptococcal infections, an infection that newborns get very soon after birth, or they develop soon after birth, a very serious infection. And she urged me to take the long view. It meant nothing to me at the time. I was like, what does she mean? You know, do you know what she means? I had no idea what she meant. But I have returned to that phrase over and over in my career, stepping back when I face challenges or things just seem really difficult, to try to think of what's the long game on this. And I think that's really good advice for us right now in everything that we're doing. And it was really helpful for me in the Group B strep work.
A photo of a man and 5 women standing in a row smiling at us. Text, Group B Strep Consensus Meeting, California, March 1995.
My work on Group B strep became much more meaningful after I was contacted by Gina Burns, and she's the woman standing next to me in white here. She had lost a baby to Group B strep, and she, in 1990, worked with other parents around the country to organize, to form a new group called the Group B Strep Association, and try to raise awareness about this condition. She was really stunned after she lost her baby to read about the disease and find out that there had been trials looking at prevention nearly a decade earlier, many years before, but that she didn't know about it and had no opportunity to do anything. So other EIS officers, Ken Zangwell, when he was EIS, and Cindy Whitney, who's shown on the right here, worked to synthesize the evidence base on our surveillance, what we knew about the disease, the prevention trials that had been done, the opportunities for prevention, and pulled together a draft guideline on prevention of Group B strep in newborns. We were able to hold a consensus meeting together with the California Health Department. The obstetricians were there, the pediatricians were there, public health was there, microbiology was there, but the parents were there also. And I think the sense of urgency that the parents had really helped the medical community realize that doing something was better than doing nothing. And out of that came another MMWR, recommendations for prevention of perinatal Group B streptococcal disease, which were taken up by the obstetric community. I could say the rest is history, but it was really, again, a heady experience to work on a national guideline based on evidence that the agency had helped pull together, work with clinical groups, and make a huge difference for families.
A line graph titled, Invasive Early Onset Group B Strep Disease, U.S., ABCs, shows years from 1989 to 2015 on the x-axis and cases per 1,000 live births from 0 to 2, in increments of 0.2, on the y-axis. A point is plotted on the graph for each year and connected to form a line with a downward trend. It beings in 1989 at just above 1.4, peaks in 1992 at about 1.8, then drops down to just above 0.4 in 1999, then down to about 0.2 by 2015. The dot at 1992 at about 1.8 is labeled, first ACOG and OP statements. The dot at 1995 at about 1.25 is labeled CDC draft guidelines published. The 1997 dot at just above 0.8 is labeled consensus guidelines. The dot at 2002 at just above 0.4 is labeled universal screening. Text, more than 100,000 GBS cases prevented. Source, ABCS/Emerging Infections Program Network, CDC, www.cdc.gov/abcs.
I don't know if Stephanie Schrag is here. She did incredible work in when she was an EIS officer and then in the years that followed to update the guidelines based on an elegant cohort study she did with the ABCs, or the part of the Emerging Infection Program Network. And we estimate over 100,000 babies have been born now without this infection, have been saved from getting this really life-threatening infection.
A photo of 13 African men, 2 white men, and 1 white woman pose in 3 rows standing outside of a building and smile at us. Text, Meningitis Control Guidelines Meeting, Niamey, Niger, 1994.
So EIS has been global for much of its history. Several officers at the agency have worked on epidemics of Group A meningococcal meningitis, which used to plague countries in the meningitis belt in sub-Saharan Africa. At that time, large epidemics periodically occurred where tens of thousands of people across countries would be affected. These outbreaks were not just deadly, they were very disruptive, with all health services being stopped in order to divert and deal with the epidemics. Meningococcal meningitis can kill or disable otherwise healthy young people, teens and young adults. There's just a long history of EIS officers working on meningococcal meningitis, and I was excited to see, I think it's Medora today, talking about meningococcal meningitis after UMRA, which is really continuing a long tradition. But back in the day, before my time, Art Reingold and Gail Bolin worked on this, and then Brad Perkins, Nancy Massonier, Tom Clark, Amanda Cohn, and Ryan Novak.
Public-private partnership, low-cost meningitis A conjugate for African meningitis belt, greater than 300 million doses delivered, meningitis A. Epidemics eliminated. An article headline. Text, Science and Technology, Preventing Meningitis. Knockout jab, a vaccine that rarely makes the news is a big public health success. A map of the meningitis belt of Africa showing countries shaded in either blue, red, or gray, from Mauritania down to Guinea, through to Ethiopia and Kenya, including Congo and Uganda, and most countries in between. A photo of Fabian Diamond and Ryan Novak walking along a railroad track, each carrying 2 white cases with handles in one hand.
One of the most consequential partnerships in public health history is illustrated here. The meningitis vaccine project was led by an EIS alum, Mark LaForce, working with PATH and the World Health Organization, with Serum Institute of India, with countries in the meningitis belt. This project developed a very low-cost conjugate Group A meningococcal meningitis vaccine specifically for the countries that needed it the most in the meningitis belt. They didn't just develop the vaccine, they scaled it up, and the countries were able to vaccinate through campaigns over 300 million people. Meningococcal A epidemics have been eliminated. So in the photo here, you can see Ryan Novak and Fabian Diamande of the meningitis branch working on surveillance and colonization work that really helped prove that this bacteria was no longer circulating.
A cropped version of the photo of the people standing in the office shows just one man. A microscope image shows purple cells with dark spots inside surrounded by short curved lines. An article from a newspaper with the headline, Florida Man Dies of Inhaled Anthrax, beginning with, text, Lantana, Florida, a 63-year-old Florida man died of the inhaled form of anthrax yesterday in the first such death in the United States in 25 years. Text, preparedness efforts led to rapid recognition, alert, and lab confirmation.
So Brad Perkins, in addition to working on meningitis and eventually leading the meningitis branch, in the late 1990s started to work on preparedness efforts. These included efforts to train the state public health labs to recognize or to confirm Bacillus anthracis. There were fears about bioterrorism, and this was a big effort. Unfortunately, the labs got a chance to try out their new tool. In October 2001, shortly after the 9/11 attacks, an astute clinician in Florida named Larry Bush saw a patient with fever and confusion. He collected spinal fluid and saw this pattern, which is called the boxcar pattern. Larry Bush, unlike someone like me, remembered that the boxcar pattern goes with anthrax. And so he alerted his health department, and the health department and CDC were able to confirm the diagnosis. This was the beginning of multiple anthrax cases detected in states around the country.
October 15, 2001. An envelope addressed to Senator Daschle's office in D.C., with the return address from 4th grade, Greendale School, Franklin Park, NJ. A timeline shows the number of cases for symptom onset dates from September 17 to November 16, 2001. The envelopes were mailed to news media companies on September 18. There was one case in NYC and one in NJ from September 22 to the 26th, and a few cases in NYC, NJ, and Florida from the 29th through 30th. Anthrax was first confirmed around October 4. On October 9, envelopes were mailed to government leaders. There were 12 cases in NYC, NJ, DC, and Connecticut between October 14 and October 26, with 4 cases in DC on one day. Then there was one case in Connecticut on November 15. Text, https://www.cdc.gov/eid/article/8/10/02-0353_article.
The anthrax spores were part of letters that were sent in 2 batches. The first batch was sent to the media. The second batch was sent to government leaders, including Senate Majority Leader Tom Daschle. Another EIS alum, Dan Jernigan, who's now the center director for the NCZID, I think it's called, he was able to put the story together with this graph on the bottom right. We learned a lot from the anthrax attacks. One of the things we learned was that bioterrorists don't have to follow the rules of nature. So the first cluster of cases represented exposure to the first batch of letters. The second cluster of cases represented exposure to a much more lethal set of letters. And there were several inhalational cases in the second batch. Tragically, postal workers at the Washington, D.C. Brentwood facility shown on the top right lost their lives because of this. We had a false sense of security after the first batch of cases, or the first batch of letters, that postal workers in these distribution centers didn't seem to be at risk. But the higher lethality of the second batch meant that that was not true. So a really painful, for families and the community, way to learn that bioterrorists can do whatever the heck they want. It's also worth remembering that Alex Langmuir had advocated to establish the EIS back in, I thought it was 1951, but I think something said 1949, based on concern about civil defense against biologic warfare. And so sadly, EIS officers in 2001 got to work in response to these terrorist attacks. Virtually all of the EIS officers that year deployed or were part of the anthrax and World Trade Center response.
Text, 2011, Hollywood. A poster for the movie Contagion, starring Lawrence Fishburne, Jude Law, and Kate Winslet. A flowchart titled, 2003, Actual Spread of SARS, shows Hotel M Hong Kong in the center with a network of color-coded boxes branching from it, including hospitals 1 through 4 in Hong Kong on one side, and various countries on the other side, such as Canada, Ireland, the US, Germany, Singapore, and Vietnam. Text, MMWR, March 28, 2003, 52, 12, 241-248.
Sometimes the movies takes on our work directly. So, I think there's a love story out there that the movies could make, but usually they go with the disaster or thriller or action genre. So we did, of course, get several A-list actors to play EIS officers or CDC or State Health Department people. If you saw the movie in 2011 and thought it was kind of over the top or unrealistic, you probably were not aware or hadn't been paying attention in 2003 when the diagram on the right actually occurred. And for this, Rana Haje and Cindy Whitney were part of this Hotel M story. The Metropole Hotel in Hong Kong was the scene where an individual shown in red, who was literally a pulmonary doctor from Guangdong province in China, traveled to Hong Kong and stayed in that hotel. Other guests at the hotel who stayed there the same 2 nights he was there actually developed SARS, the first SARS coronavirus, and began outbreaks in their home countries, a number of countries, as well as multiple hospitals in Hong Kong. Again, pretty much the whole EIS class was part of this response.
A photo of N posing with EIS officer Wei Gongzhou in front of the Beijing CDC building. They stand behind a large red banner across the sidewalk that says SARS along with Chinese characters. Text, selected findings from Beijing 2003, risk factors for community-acquired cases included visiting a fever clinic, unrecognized nosocomial spread, wearing masks in community protected, quarantine measures were effective.
I got to travel to Beijing with Wei Gongzhou and Kathy Chow, EIS officers, that year to help the Beijing CDC and the World Health Organization in China respond to the SARS outbreak. We learned a lot from the outbreak there. The full SARS outbreak was about 8,000 cases, 800 deaths, and about $40 billion of economic loss from travel and trade interruptions. But we were able to show that what looked like it was community transmission of SARS was actually acquired by people who were taking loved ones into fever clinics and were getting exposed to the virus in those clinics. We were able to show that masks were actually protective in the community, something that was one of the few pieces of data we had in 2020 when COVID-19 occurred. And they were also able to show that quarantine measures were effective.
A photo of Anne and a woman shaking hands, posing for a photo, in front of a Dongfeng car with a red bow on its hood. The woman smiles at the camera while Anne laughs. Text, Beijing CDC, SARS response, May 2003.
Now, EIS is about consequential epidemiology. It's about working 24/7, but an added benefit is that you get to work with extraordinary people. And the relationships that are developed when you are working really hard with state and local and global partners on really difficult problems, those relationships can be personally gratifying. My counterpart, Dr. Gongzhou here, was able to maintain her professional demeanor in this little snapshot. Me, not so much. We had left this intense meeting and saw the truck with the bow on it and thought, oh, well, let's just pretend that the Americans are giving the Chinese this truck. But it was a better idea than it turned out to be.
CDC and eradication partners join earlier polio heroes. A black and white photo, captioned Polio Hall of Fame, Warm Springs, Georgia, of a row of people standing in front of a wall with several bronze busts of men hanging on it above them. A photo shows Anne, in uniform, standing with 2 other women behind a plaque that says, Global Partners, New Inductees for a New Century, with the CDC and UNICEF logos.
So, EIS also has an incredible history of working on vaccine-preventable disease and immunization. For the new people, it's incredible to me to think that 70 years ago this week, the Alex Langmuir, they were having an EIS conference like this. It was a lot smaller, but Alex Langmuir stopped the conference and sent everybody back to their states because a couple cases of paralysis had just been reported in children who had just gotten the very new Salk polio vaccine. It was an emergency, and EIS was on the case. And with very rapid investigations and a whole lot of effort, up and down, the decision-making chain, they were able to identify that the Qatar Labs polio vaccine was the source of most of these cases and not the other manufacturers. And polio vaccination could continue, and we are now, as we say in the field, this close to eradicating polio. In 1958, in Warm Springs, Georgia, where FDR had gone to take the waters after he developed polio, they built a polio hall of fame, recognizing Jonas Salk and Albert Sabin and other original scientists and advocates who had helped get polio vaccines to be a reality. 50 years later, in 2008, a few of us from CDC were able to join colleagues from UNICEF, the World Health Organization, and Rotary International in being inducted into the Polio Hall of Fame. The implementing partners of the Global Polio Eradication Program have made a huge difference. And so that terrible beginning with the Qatar incident is now leading us to a point where only 2 countries still have wild polio virus circulating. And I think Margaret is here someplace, so one of the folks in the picture is here. I promised you that there's a picture of us.
An article from MMWR on April 24, 2009 titled, Swine Influenza A, H1N1, Infection in 2 Children, Southern California, March through April 2009. Photos. The headline, Swine Flu Fears, Going Across a Digital Ticker on a Building, a newspaper headline. Swine flu spreads, and students walking out the doors of a school with a banner above that reads 150 years St. Francis Prep. Text, St. Francis Prep, the swine flu aftermath.
Yeah, so 1 year after the polio party, we detected 2 cases of a new influenza strain in young children in Southern California. We didn't know if it was something or nothing, but very soon thereafter we realized it was something. This was the first influenza pandemic of the 21st century. Children and young adults were the hardest hit. We were very lucky that this particular virus relatively spared the elderly.
Text, Susan Cooper, Tennessee Health Department. Susan smiles as she crouches on the floor and opens a cardboard box inside a styrofoam box. Text, First day of H1N1 vaccination, Le Bonheur Children's Medical Center, Memphis, October 5, 2009. Anne and Susan stand together speaking in front of a row of camera people.
Even though influenza vaccines have been made for decades, it wasn't until early October when we got the first doses. And Susan Cooper from the Tennessee Health Department actually picked up the first boxes of the vaccine and brought them to the Children's Hospital in Memphis, where we launched the campaign. This slide is my reminder to tell us how important the relationships between state and local public health and the federal part of the government are. These are real partnerships. Some of you will be fortunate enough to work in the health departments in states embedded for CDC, and some of you will be at headquarters or overseas, but it's an incredible partnership that's really protecting Americans.
Text, West African Ebola pandemic. A photo shows a large sign out front of a metal shack with people milling about out front. It has the Save the Children logo and the text, Project, Minor Renovation Work for Health Center, renovation of wooden walkway, construction of concrete bridge. Another photo shows an Ebola treatment ward in Monrovia, Liberia in September 2014. It shows a row of people lying on mattresses on the floor of a large tent.
So in July of 2014, maybe some of you were in the EIS class of 2014, I was actually speaking, doing a little lecture for the summer course, and one of the guys, or one of the young people, asked me, oh, there's some cases of Ebola happening in West Africa. Might EIS officers get a chance to be part of that? And I said, well, if you have international experience and you've got the right kind of credentials, I do think there may be a few opportunities. Little did I know that every single one of the EIS officers during 2014 and 15 was part of the Ebola response. It might not have been in Liberia or Guinea or Sierra Leone. It might not have been in Dallas. I'm sorry if you were one of the people in Dallas. It might not have been at the airports where you were screening all those travelers, but you were part of this incredible response. And I think 2014 really was, the beginning of the new normal, that there was always a big emergency response going on. And that is one of the reasons that EIS exists and that CDC exists. And so the West Africa Ebola epidemic was completely unanticipated, a new region, really lethal. We didn't know Ebola epidemics could cause tens of thousands of cases and so many deaths, but it did.
A photo of 13 men and women standing together outdoors smiling in the sun. Text, Thanksgiving in Freetown with some of the STRIVE team, Sierra Leone trial to introduce a vaccine against Ebola.
Some of the EIS officers and alumni were part of something called STRIVE, the Sierra Leone trial to introduce a vaccine against Ebola. And I am really proud of this whole team that worked together with individuals from the College of Medicine and Allied Health Sciences in Sierra Leone and the ministry there to not just study safety and immunogenicity of an investigational Ebola vaccine, but to also use that study to make the vaccine available to 8,000 frontline healthcare workers. The CDC study was able to provide data that helped with licensure of the vaccine, but a World Health Organization study of the ring vaccination approach to the use of the same vaccine was able to show that the vaccine was almost 100% effective. That vaccine has now achieved licensure and is stockpiled by Gavi for use in outbreaks which have continued to occur.
A line graph titled, Confirmed Ebola Cases by Week and Country, June 2014 to June 2015, WHO. It has lines for 3 countries, Guinea, Liberia, and Sierra Leone. The 3 lines begin at 50 or below cases on June 22, 2014. They each grow, with Sierra Leone peaking the highest and for the longest at around 500, and Guinea only reaching about 150 at its peak. Liberia peaks at around 350. Vaccine trials were launched in the 3 countries between February 1, 2015 and March 29, 2015. Each line drops dramatically around February 1 with Liberia reaching 0 by March 29, and both Guinea and Sierra Leone ending on June 21, 2015 at around 10.
One of the lessons of the Ebola outbreak was even though everybody involved with the vaccine trials in the 3 countries felt like we were moving at lightning speed, the traditional approaches to control of that epidemic were able to interrupt it before the vaccine trials really got launched. And it was a wake-up call that we need to do things differently if we want countermeasures to be available for study and for use during responses, during emergencies. One of the after effects, I guess, of this recognition was the formation of the Coalition for Epidemic Preparedness and Innovation, CEPI, which is a lot like BARDA actually, but it's basically investing in epidemic-prone disease countermeasures to have them ready for investigation when emergencies hit. And CEPI was crucial, working as part of COVAX during COVID-19 to help get a lot of products invested in that could, some of which bore fruit.
Newspaper headlines, The Wall Street Journal, vaping-related injury cases near 1,500 with 33 deaths. Public health officials still don't know what specifically is causing mysterious illnesses. The New York Times, Bronx teenager's death is the youngest vaping fatality in U.S. The 17-year-old who died last week is the youngest of 23 people to die nationwide of a vaping-related lung illness. The Atlantic, the actual harms of vaping, in a moment of national panic, what is the safest way forward? A photo of a protest with people holding handmade signs, saying, flavors help to quit, we vape we vote, prohibition doesn't work, and mango is not a crime. Another photo shows people wearing matching yellow t-shirts that say Parents Against Vaping on the back.
Not every emergency or outbreak that EIS and CDC and state health departments respond to is infectious or communicable. In 2019, young people in a number of states developed life-threatening lung injuries. Pediatricians in Wisconsin noticed when 3 such teenagers were admitted to their hospital that something was going on that was just not normal. The teens and young adults had been vaping before this, and there was really elegant work done by the Illinois Health Department, by Wisconsin, and by states across the country to rapidly respond to this new problem and take action.
A bar graph titled, Hospitalizations for EVALI declined when CDC issued health advisory, before sources identified. The graph shows March 31st to February 9th on the x-axis and number of patients from 0 to 240 on the y-axis. The bars are close to zero up until after June 9th, reading about 10 by mid-June, then 40 by mid-July, then jumping up to 160 by mid-August. The bars peak at almost 240 by September 22nd. The bar to the left of September 22nd, at about 230, is labeled, National Health Advisory issued. After September 22nd, the bars fall steadily, reaching 120 by October, 60 by December 1st, then down to about 5 by February 9th. Text, EVALI, e-cigarette or vaping product use associated lung injury. https://www.cdc.gov/tobacco/basic_information/e-cigarette/severe-lung-disease.html.
So if you needed to leave this talk with one picture of consequential epidemiology, it would be this slide, which is hospitalizations for e-cigarette or vaping-associated lung injury across the country. More than 2,000 such cases of really severe intensive care unit kind of lung injuries in young people. CDC issued a national health advisory and cases fell. When the advisory went out, we didn't know the actual specific cause or causes of the outbreak, but action had to happen. And it was in the weeks that followed that clarity emerged about what particular sources were the riskiest.
A woman in a white coat, safety glasses, and gloves holds a vape pen in a lab with a rack of vape pens on the counter matched with vials. Text, vitamin E acetate was found in 48 of 51 BAL samples from confirmed EVALI patients. Direct evidence of vitamin E acetate at the primary site of injury within the lungs. An article in the New England Journal of Medicine titled, Vitamin E acetate in bronchoalveolar lavage fluid associated with EVALI.
There was very elegant work done by the National Center for Environmental Health's laboratory to develop new assays in real time for all these different toxins to test in specimens collected from patients with lung injury and in control patients who had lung procedures for other reasons. They found direct evidence of vitamin E acetate at the principal site of injury in the lungs. Working together with labs at the FDA, the same vitamin E acetate was found in samples of THC vaping cartridges that were used from cases, as well as some that were just collected. So this was a really nasty disease with a very pump handle-like intervention, a broad warning to avoid e-cigarettes and vaping until we know more, and a lot of lives saved.
Another cropped version of the photo of the people in the office shows one man. Text, COVID-19. A 3D illustration of the microscopic sphere of the virus covered in red projections.
Actually, I wanted to say one more thing about EVALI. This was one of the first times I was aware of a massive emergency operations center being set up at Chambly. All of the centers at Chambly were part of that EOC, and many of the experts from preparedness and infectious disease and surveillance groups helped with the response. We really needed the tobacco experts. We needed the toxin experts. We needed the guys who knew what was going on with THC and cannabis and vaping cartridges, as well as a lot of other partners who understood the illicit supply of tainted products. And so it was a real testament to the kind of thing that EIS can do, surging when there's a national emergency. So I guess I have to say something about COVID. See that my time is near over, so it won't be very long. But it brings me back to that initial gang that I showed you at the beginning of the talk. I want to recognize one of those EIS officers that was part of our branch. This is Frank Rito. He was an EIS officer in the Meningitis and Special Pathogens branch. Not every EIS officer stays at CDC or works in state health departments. Frank was one of the EIS officers who went into infectious disease practice after he finished the EIS program. And we're really lucky that he did. In Seattle, King County, where he was working up an outbreak of pneumonia among nursing home patients, and none of the usual causes emerged. And so he really pushed to get COVID testing done when it was really hard to get COVID testing done. We don't want to even remember that time. Sure enough, Frank really sounded the alarm of a horrible nosocomial transmission of COVID-19 early in the pandemic. Transmission within nursing homes, transmission between hospitals, people being transferred back and forth, the kind of thing our Division of Healthcare Quality Promotion had been working on with antimicrobial resistance, but just was horrible in the beginning of COVID. And so, Frank played a really important role at that time. Another EIS alum, Jeff Dushin, was the Seattle King County health officer at the time and led a family of projects to try to control the outbreak in the Pacific Northwest.
Text, Community COVID-19 Burden of Disease, January versus May 2021. Two side-by-side U.S. maps color-coded by county, one on January 2, 2021 and one on May 19, 2021. The counties are blue for moderate burden resolving, red for resolving, pink for high/sustained, yellow for moderate, and green for emerging. The January 2 map is mostly red, with a swath of green down the center of the country, accented with blue. The May 19th map is mostly green.
You will remember that in early January 2021, the whole country was really affected greatly by transmission of the virus. The county plots that you see there are really stunning. But because we got scaled up effective vaccines in a pretty incredibly short time, by May, most of the country had really taken up that vaccine and transmission was greatly improved. I like to show this slide because May 19th was the week when I announced I would be retiring from CDC. And it seemed like a pretty good time. So I really did not know that, very soon thereafter, the Delta variant of COVID-19 or of SARS-CoV-2 was coming. And so that summer, we saw Delta, and then we saw Omicron, and then, you guys dealt with everything else that I don't even know the letters for.
A bar graph titled SARS-CoV-2 Variants Circulating in the United States, May 30, 2021 to September 4, 2021. Each bar, from June 5, 2021 to September 4, 2021, in increments of 1 week, is color-coded based on variant. The first 2 weeks are mostly blue for the Alpha variant, followed by orange for Delta. By week 3, the bar is mostly orange. The orange grows in each subsequent bar, with Alpha disappearing by the second to last week.
There was a lot of loss of life, of disruption, just huge toll on the country and the world, particularly among people who were not vaccinated or among the elderly. We had learned during the anthrax response that bioterrorists don't have to follow the rules of nature. With the COVID variants, we learned that viruses don't have to follow the usual rules. And so patterns that we were finding early in the response with a susceptible population and a highly effective vaccine wouldn't necessarily work later on when new variants evolved or in a different immunologic context. So vaccines continued and do continue to remain very effective against severe disease. But we learned in that summer that the thought that they could prevent transmission and that we could get rid of our masks was premature.
Text, celebrating CDC's COVID vaccine task force at the Service to America medals. Anne poses for a selfie with Anita Patel, Amanda Cohn, and David Fitter.
The pandemic was a really hard time for the country and the world, and for public health and for CDC as well. But occasionally there was good news. Leaders from CDC's vaccine task force, Anita Patel, Amanda Cohn, and David Fitter, representing the whole vaccine task force, were recognized by the Partnership for Public Service with what's called a SAMMY's Award, the Service to America Medal. They were recognized for the partnership with pharmacies that initially vaccinated all the nursing homes in the country, and then many others. They were recognized for the ACIP heroic effort to review data on safety, effectiveness, impact, logistics for so many different vaccines as well as their indications. And they were recognized for the Vaccine Task Force heroic work to reach communities that had initially been reluctant or distrustful of vaccines, and to really narrow the gaps in vaccine coverage early on. So then NCIRD Director Jose Cordero and I were thrilled to be able to celebrate their award with these individuals.
Boxes printed on a wall interconnect and hold the text, to be a diligent steward of the funds entrusted to us, to provide an environment for intellectual and personal growth and integrity, to base all public health decisions on the highest quality scientific data, openly and objectively derived, to place the benefits to society above the benefits to the institution.
COVID-19 wasn't the only hard time that the agency and public health have been through over the decades that we've existed. Now we're in the midst of some more hard times, with measles outbreaks, with avian flu challenges, and continued high, though decreasing, death from opioids, heart disease, and cancers. And after intense efforts to respond to the COVID pandemic and to recover from it, disruptions in funding and staffing are now placing really large burdens on the communities they serve, as well as on the public health workers who remain behind to pick up the work. In this kind of really daunting period, I find it can help me to return to the pledge to the American public that Walt Dowdle, another hero in CDC's history, he was the deputy director of the agency for many years. He created a pledge to the American public, which is enshrined on the walls of the infectious disease building on the Clifton Road campus. And he committed us to base all public health decisions on the highest quality data, openly and objectively derived, and to place the benefits to society above the benefits to the institution. When I had those hard days during the 33 years I was at CDC, these words really helped me, and I'm so proud to have been part of an institution and programs that really lived this pledge.
Reflections on Consequential Epidemiology and the Future of EIS. Take the long view, ask the right questions, seek long-term solutions. Expect the unexpected, adapt to uncertainty. Communicate with empathy and honesty. Learn from mistakes. Collaborate across disciplines. Engage communities. Be humble. A photo of Anne, in uniform, standing at the front of a small audience and speaking with a woman in the front row.
So I'm not sure I can muster the wisdom of Bill Foege or Walt Dowdle, but let me leave you with a few reflections on consequential epidemiology and the future of EIS, because I'm sure there is a future for EIS and many of you are going to be part of it. Try to be consequential in your epidemiology. Take that long view in the problems you tackle by looking for long-term solutions and not just quick fixes. Whether it's emerging infections or geopolitical upheaval, we need to expect the unexpected and be agile in adapting to uncertainty. Let's communicate with empathy and honesty. Avoid absolutes. Try to meet people where they are. Try to talk in ways that people can understand and help that science lead to action that can save lives. Let's learn from our mistakes. Let's collaborate across disciplines. In my era, it was like getting economics and behavioral science into EIS and into public health. Now it's bioinformatics and genomics and artificial intelligence and on and on. But let's embrace different disciplines and do multi-sectoral work. And let's engage communities. This may mean finding the trusted messengers who can help bridge the divide between what we do and what communities really need, and can be there to try to counter the noise of the social media and some of the misinformation and disinformation. And lastly, let's be humble. So I talked about movies, and everybody knows I like musicals, and so I kind of wanted to end with a little bit of a nod to musicals.
A photo of the CDC building. Text, history has its eyes on you. Logo, CDC 24/7. Text, for more information, contact CDC, 1-800-CDC-INFO, 232-4636. TTY, 1-888-232-6348. www.cdc.gov.
In the words of the musical Hamilton, remember that history has its eyes on you. I'm not going to sing that for those who know the musical.
You can do it. A photo of Anne and another woman posing with two women dressed as superheroes, standing in front of a poster that says Guardians of Public Health.
But you can do it. So that is my main talk. Question if I'm going to sing. Okay, guess I'm looking at, okay, all right, we have time. Okay, I have to collect my thoughts. Okay, so, all right. Okay. So we seem to be okay on time, so I think I have two selections for you. The first one I'm going to sing, and then the second one is a sing-along, okay? Because as many of you who know me know, I have a terrible voice, so. Cover your noses and ask where'd they visit. Methyl, not ethyl, no wait now, which is it? Sensible measures and 99s, those are a few of our favorite lines. When the flu comes or Ebola and we're feeling sad, we'll simply remember our favorite lines and then we won't feel so bad. Enterovirus acute myelitis, low-grade pyrexia with painful orchitis. Make it plain English in meal snacks and bites. Those are just some of our favorite rewrites. When there's coughing or a camel or the press is mad, we'll simply remember our favorite lines and then we won't feel so bad. Sharing dilemmas and showing compassion. Supply, yeah, demand, sure, but never say ration. Variant mismatch or SARS-CoV-3. Those all were favorites, of course, HPV. When the flu comes or corona and we're feeling sad, we simply remember our favorite lines and then we won't feel so bad. That's it on that one. Okay. So the last one, the next one, which is the last one, if I can remember it, there's a chorus that you guys can join into, which you'll catch on when I point like this. You have to sing. Okay. What would you do if I sang out of tune? Could you keep the tomatoes at bay? In 20 years, they'll be over the moon because of all you are doing today. Diseases go bye-bye with a little help from our friends. That's the part you sing. So diseases go bye-bye with little help from our friends. Coverage will be high with little help from our friends. Fewer children die with little help from our friends. Have you seen any measles? No, that's gone. Polio, too. Do you still use those needles? Vaccines come in patches now, too. Pandemics go bye-bye with a little help from our friends. Plenty of supply with little help from our friends. You're the reason why with a little help from our friends. You've been a great audience. Okay.
Logos, Department of Health and Human Services, CDC. Text, and Schuchat, MD, Consequential Epidemiology, an EIS Love Story. April 24, 2025.